Now let's look at a more complex scenario. A patient presents to the emergency department with multiple lacerations due to a knife fight at a local bar. After examination, it was determined these lacerations could be closed using local anesthesia. The areas were prepped and draped in usual sterile fashion. The surgeon documented the following closures: a 7.6 centimeter simple closure of the right forearm, a 5.7 centimeter intermediate closure of the upper right arm, a 4.7 complex closure of the right neck, and a 10.3 centimeter intermediate closure of the upper chest. I'm going to show you how I write this down when there's multiple lacerations like this, so you can do it when you have a complicated question like this. As you can see, I wrote down 3 columns for simple, intermediate, and complex. Any wound that was repaired that's simple, I put under the simple column, so that was 7.6 for the arm, 5.7 for the arm under the intermediate, and 10.3 of the chest. Complex repair was 4.7 of the neck. Since there were 2 different wounds repaired in the intermediate section, I looked in the CPT book to see if the arm and the chest were grouped together in the same code. And they were, so we have to add those together. After adding those together, I got 16 centimeters. First, let's code our simple repair. It was of the arm for 7.6 centimeters. So first we're going to look for our body area in the code. And the first one is for scalp, neck, axilla, genitalia, trunk, or extremities. So our arm is included in extremities. Then we're going to look for the size, 7.6. So our first code will be 12004. Next, we're going to code our intermediate, and we're going to look for our body area for the arm, which is included in the extremities here, and then for the chest, which is also in the same code, so we can add them together. When we add the arm and the chest together, it adds up to 16 centimeters. So our code is 12035. Lastly, we're going to code our complex repair. It was of the neck. 13120 is of the scalp, arms, and legs, so that's not the category. 13131 is of the cheeks, chin, mouth, neck, so that is our category, and it was 4.7, so we're going to code it with 13132. So we should have had 12004, 12035, and 13132. Another guideline that you need to remember for the repairs after reading the guidelines is adhesive strips are not coded because it is included in the office visit. So if an adhesive strip is used to repair a wound, do not code that procedure. Now turn to the adjacent tissue transfer section. Patients who should undergo adjacent tissue transfers or rearrangements are those who want to cover up skin imperfections, including scars, lacerations, lesions, and traumatic wounds. The main advantage of an adjacent tissue transfer over skin or tissue graft is that a part of the flap remains connected to its origin. This way, the flap has an intact and continuous blood supply. A skin graft is a piece of tissue that is separated completely from the origin. Thus, it has to wait for new blood vessels to grow before it can receive blood again. An adjacent tissue transfer or rearrangement is performed in 2 stages. The first stage is when the local flap is taken from the donor site and sewn into the site where the lesion or skin defect is located. The 2 sites are connected together by a bridge of tissue called a pedicle flap. The second stage of the process is when the flap pedicle is cut permanently. This stage is performed only when the flap already receives blood from a recipient site and thus no longer needs blood supply from the origin site. Once the pedicle is cut, the tissue repair is complete. The recipient site refers to the area of the defect that receives a graft. The donor site is the area which healthy skin has been taken for grafting. Types of adjacent tissue transfer are Z-plasty, W-plasty, VY-plasty, rotation flap, random island flap, or advancement flap. The first thing you need to do is focus on the size in square centimeters. If the square centimeters are not given, you will need to times the length by width. Write that formula down in your book. The location of the defect recipient site should be identified as well. Excision of lesion that is repaired by adjacent tissue transfer is never coded separately, so you cannot code the repair separately. If a skin graft is required to repair the donor site, then a complex repair code can be billed separately. If the recipient and donor site both are required for skin graft, then size of both sites are added and selected for the appropriate code. Now turn to the skin replacement surgery section. Before we go over these codes, you need to know the different types of grafts. An autograft is taken from the patient's body. An allograft is taken from a donor's body. An xenograft is taken from a different species. The code range for skin replacement surgery is 15002 through 15278. These codes report site preparation using a variety of grafting materials and repair methods using skin or skin substitutes. If the recipient site, which is the site of the defect, requires surgical preparation before the repairs, that's reported with an additional code of 15002 through 15005 and is based on location and size of the defect. The second part is the graft. It is coded with range 15040 through 15278. Coding is based on 100 square centimeters or 1% of the body area for infants and children. Guidelines state a child is less than 10 years of age. Measurements are based on the size of the recipient site, the site being repaired, and not the donor site, graft site. For multiple wounds, add together the size from all anatomical sites that are grouped together in the same code descriptor. Look at free skin grafts 15200 through 15261. These are pieces of skin that are completely freed from the donor site and placed over the recipient site. They are either split thickness or full thickness and are reported by recipient site, size of the defect, and type of repair. Now let's look at the flap section. Flaps are coded based off of the recipient region, not the donor site, when a flap is being attached in a transfer or to a final site. Code based off of the donor site when a tube is formed for later transfer. Repair of the donor site that requires a skin graft or local flaps can be coded separately. You should make a note on the flaps page that repairs can be coded separately. Now let's look at burns. In your CPT code book, there is an illustration of the Lund-Browder diagram, a classification method table for burn estimations that you'll use when coding the burns, local treatment category. This method is used for estimating the extent, depth, and percentage of burns, allowing the varying proportion of body surface based on age. Code 16020 is for the initial or subsequent dressing, change, or debridement of a small surface area defined as less than 5% of the total body surface area. 16025 is medium, or 5 to 10% of the total body surface area. 16030 is large or greater than 10% of total body surface area. Let's look at the diagram in our book now. This is the diagram. Let's say that you're coding a procedure where a 5-year-old was burned on their left arm and their right arm. You'll go to the 5 to 9 section and go down to the right arm, and then you'll go to the 5 to 9 section and go down to the right arm. If you add those two together, you have 7. So this will be coded with 16025. Now let's look at the destruction section. Destruction means the ablation of benign, premalignant, or malignant tissues by any method, with or without currentment, including local anesthesia and not usually requiring closure. Remember, destruction is different than an excision. Don't get those confused. If a lesion is destructed, it should be coded from this section. Usually methods that are used in destruction include electrosurgery, cryosurgery, laser, and chemical treatment. Cryo means that they are freezing off the lesion. Pay attention to the type of lesion. Was it premalignant, benign, or malignant? In this section, it is coding benign or premalignant. I have bracketed on the first part the premalignant lesions. The note should specify premalignant. 17000 is destruction, premalignant lesion, first lesion. 17003 is second through 14 lesions each. That means if there are 14 lesions, you will code 17000 and 17003 times 13. If there are 15 or more lesions, you will code 17004 one time because that code descriptor does not say the word each in it. The benign lesion destructions are coded with CPT codes 17106 through 17250. For cutaneous vascular proliferative lesions, you will code 17106 through 17108. For other benign lesions other than skin tags or vascular proliferative lesions, you will code 17110 and 17111. 17110 says up to 14 lesions. It does not say each in it. So if there are 10 lesions, you will just code 17110 one time. 17111 is 15 or more lesions. So if there are 20 lesions, you will still only code 17111 one time. The destruction of malignant lesions are in a separate section. They are coded based on body area and size, just like the excision codes. Now turn to the Mohs Micrographic surgery section. Mohs micrographic surgery is a surgery technique used for the removal of complex skin cancer. A single physician acts in two separate distinct capacities, as a surgeon and a pathologist. As described in the guidelines, the surgeon removes the tumor tissue and maps and divides the tumor specimen into pieces, and each piece is embedded into an individual tissue block for histopathologic examination. If the lesion is malignant, it's immediately removed. However, this procedure usually involves stages where the surgeon removes a layer of skin and examines it for cancerous cells, then removes another layer of skin and again examines it for cancerous cells. Those are each called stages. Each time he examines it, it's a stage. The amount of different tissue specimens he cuts into pieces or into specimens is the blocks. This is repeated until there is no longer any cancerous cells identified. If a repair is performed, it may be reported separately with these codes. This is a diagram of a Mohs surgery. This is the visual lesion up here. First, the first layer of skin is removed. That is the block. Then the doctor examines it and decides if he needs to get another layer. That's the stage. If he goes to get another layer, that's the second stage. And then another layer, that's the third stage. And another layer, that's the fourth stage. When coding these, you must first determine what the body area was that Mohs was being done on. And 17311 involves the head, neck, hands, feet, genitalia, or any location with surgery directly involving muscle, cartilage, bone, tendon, major nerves, or vessels. In 17313, it is the trunk, arms, or legs. 17311 and 17313 are for the first stage up to 5 tissue blocks. 17312 and 17314 are for each additional stage up to 5 tissue blocks in that stage. If any stage ever has more than 5 tissue blocks, there is an add-on code for each additional tissue block in any stage, and that's 17315. And it also covers any location. So if we were doing a Mohs surgery where they had 3 stages, and each stage had less than 5 tissue blocks, or had 5 tissue blocks, except for the third stage, it had 6 tissue blocks. You would code 17311 for the first stage, 17312 for the second stage, 17312 for the third stage, and since the third stage had 6 tissue blocks, you would code 17315 for the 6th tissue block. The breast section is in the back of the integumentary section. The breast procedures are divided according to the category of the procedure: incision, excision, introduction, repair, and or reconstruction. Breast biopsies are reported with codes 19081 through 19101 and are divided by percutaneous or incisional, with or without imaging guidance. Image-guided breast biopsies include the placement of localization devices when performed. When an image-guided placement of localization device are provided without a biopsy, codes 19281 through 19288 are reported. Some common codes are mastectomy procedures, and they are found in 19300 through 19307. You need to read the operative report carefully to determine which, if any, muscles and lymph nodes were involved, since that will determine the code selection. 19305 is for reporting a mastectomy radical, including pectoral muscles and axillary lymph nodes. It is radical because they are taking that muscle and lymph node. So if they are taking that in your note, but they don't say the word radical, it's still 19305. 19306 is a radical mastectomy, including pectoral muscles, axillary, and internal mammary lymph nodes. The repair and reconstruction codes not only are used for reporting reconstruction after a mastectomy, but they're also codes for mastopexy, also known as a breast lift, or reduction mammoplasty, also known as a breast reduction. Next to mastopexy, you should write breast lift. And next to mammoplasty, you should write breast reduction, because they might not use those terms. That's the end to the integumentary system. It's one of the harder systems in the CPT book, so if you need to watch these videos over, please do so. Also, make sure to utilize the guide that is provided to you in the study files, as well as the flashcards for the terminology.